The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. Kathy Robinson here from the National Association of State EMS Officials. While we give the internet a moment to catch up and get everybody in the room, we're going to get started in just a few seconds. We're so happy that you were able to join us today. We know that there's a lot of interest in the topic of sharing EMS overdose data, and I would like to introduce my colleague Mary Hedges, who's been working a lot with this project and has a little bit more background and introductions than I have available. So thank you again for attending. Just a reminder, the PowerPoint presentations are going to be available in the handouts section of your control panel, so you will be able to download those today. The session is being recorded, and we will make it available on our YouTube channel probably before Friday. Those are generally large files, so it takes us a moment to be able to do that. But without any further ado, I'm handing over the microphone to Mary Hedges. Thanks, everyone.
Well, good morning, everyone. This is Mary Hedges, and thank you, Kathy, for that introduction. Today, you're going to hear from 2 state EMS offices about their processes for reporting overdose data to the Overdose Detection Mapping Application Program, more commonly known as ODMAP. ODMAP is a tool for collecting and tracking geographical data points of suspected overdose events. It's currently in use in 49 states. It provides real-time or near real-time suspected overdose surveillance data across jurisdictions to support public safety and public health efforts in order to mobilize an immediate response to a sudden increase or spike in overdose events. Today, we're going to hear from 2 EMS offices. First, presenting will be the Maryland Institute of Emergency Medical Services Systems. They submit their suspected overdose data to ODMAP through an application program interface, or API. Now, the API allows users to transfer data collected by existing record management systems, such as an EMS data system. The second presenter will be from the Connecticut Office of EMS, who will describe another approach used in populating ODMAP. Now, Connecticut OEMS implemented the statewide Opioid Reporting Directive, known as SWORD, which populates ODMAP not through an electronic interface, but via EMS clinicians in partnership with the Connecticut Poison Control Center. So today, our speakers will be, we have 3 speakers, and in order they are Dr. Timothy Chismar, the State EMS Medical Director from the Maryland Institute for EMS Systems. Also, we have Dr. William Thompson, the Director of Data Management from the Maryland Institute for EMS Systems. After they conclude their presentation, we will have a few minutes for questions and answers. And then the second presentation will be by Catherine Hickox, who's the Regional Coordinator and Interim SWORD Project Manager from the Office of Emergency Medical Services at the Connecticut Department of Public Health. So welcome our speakers, and we will get started with Dr. Chismar from Maryland. Thanks so much for joining us.
Hi there, everyone, and thank you, Mary and Kathy, for having Dr. Thompson and I. It's our pleasure to be here with you today. And over the next about 20 to 25 minutes, we're going to discuss our experience with ODMAP, and I'll lead off with some of the clinical and legislative things that led up to us using ODMAP, and Dr. Thompson will dazzle you with the technical side. So without further ado, just by way of brief background, in 2018, Maryland law, the local bill, Senate Bill 309, required EMS to report on all opioid cases or suspected opioid cases, primarily on 4 different elements: the date and time of the overdose, the approximate address where the overdose occurred or where the person was encountered, whether the overdose was fatal or non-fatal, and whether we administered a reversal drug or not. So we realized very early on that we were going to need a system and a way to go about meeting our legislative mandate. Some of our challenges early on, as many of you know, is that EMS will oftentimes administer naloxone if the clinician has respiratory depression, but we don't have a litmus test in the field. We don't always know why the person has respiratory depression or a decreased level of consciousness. So it's not always as apparent as it may seem at first to pick out the suspected opioid overdose just by way of reviewing EMS records. So again, the challenge is trying to pick out those patients who are genuinely have respiratory depression, decreased level of consciousness due to a suspected opioid overdose. And again, this relies a lot on history, exam, clinician gestalt without a diagnostic field test. Now in Maryland, as in many of the other states, we've had a relatively high prevalence of opioid abuse, or opioid use disorder, I should say, in the population. So we knew that there were a large proportion of these cases as well, and that this would be quite challenging if we had to rely on individuals to do the reporting themselves. So before we ever got started, we realized that we needed to work on how to define a suspected opioid overdose case. One of the ways we started was actually quite simple. We said if the person got naloxone, that was going to be our trigger for reporting. Obviously, one of the things we uncovered very quickly from the pro standpoint is this offered high sensitivity. Likely we didn't miss any cases, in other words. But the con was that this had poor specificity, that we estimated based on chart review that we were overestimating cases by about 14 or 15% using the naloxone trigger itself. Now, importantly, we are looking just at 911 cases. We use a statewide PCR that's provided through Image Trend that has interfacility data in it. So in all of these cases, we've excluded interfacility transfers, just to mention here at the start. But using the naloxone as a trigger, you have up here our first run at this. We blacked out the jurisdictions to protect the innocent. And you can see just all the way down in the lower right-hand corner, you have the total number of overdoses over a 6-month period of time, 5,611. You'll see that number change as I progress through the next slide. So we said, how can we improve specificity without sacrificing sensitivity, which is the case in a lot of the things that we do. So we did an analysis, and we actually came up with 2 different ways to screen and improve specificity. One was based off of something that we call in the EMS report the primary impression. So this is what our EMS clinician thinks is going on. If this is a suspected opioid overdose or a poisoning overdose drug abuse case. And then we had something called a service-defined question, which is not a NEMSIS field, something that we've added in that tries to capture, again, at the end of the report, just frankly asking the EMS clinician, do you think the person's suffering from an opioid overdose? And you may say, well, that's kind of silly. That's sort of duplicative. If they thought that they had an overdose, why wouldn't they just code the primary impression as overdose? And one of the reasons that they might not is that the person may, for instance, have been in a motor vehicle collision, or they may have been in cardiac arrest when we arrived there. And so the EMS clinician made the primary impression cardiac arrest, for instance, or unconscious person, or motor vehicle collision. And in that case, that service-defined question becomes integral in making sure that we're not missing the person who they say, yeah, this was a cardiac arrest, but we saw drug paraphernalia on scene, and we think that opioid overdose was highly likely. So this screenshot just shows you a little peek of our what our electronic PCR looks like. We, of course, have naloxone or Narcan documented in the procedures tab, so if naloxone was given. But also, we ask a couple of other pointed questions under our opioid crisis tab. And the OOCC, I should back up just a second and mention, is our opioid operational command center that was established by the governor to deal with the opioid crisis. So again, the governor declared a state of emergency, mobilized emergency management resources, and we've been working as an EMS agency with all of our partners on this. So for For our end, we said, look, document the visit as you ordinarily would, but if you suspect this is an opioid overdose, there are a couple of key questions we asked them to answer. And the first and most important one is, do you suspect the person suffering from an opioid overdose? And that became one of our screening questions as to, what we were going to report to ODMAP and what we were not. And there are some other questions here. We've had more than half of our EMS jurisdictions also leave behind naloxone on scene for cases that are not transported, but that's a topic for another discussion. So what we arrived at finally through analysis, and you'll remember the prior number was 5,611. You'll see in the bottom right-hand corner there another 6 months of data. The same 6-month period. We've honed that down to 4,875. And through a process of reading narratives and sort of laborious analysis, we believe that this definition works a lot better, achieves a reasonable balance between sensitivity and specificity. So to sum it up, our trigger is naloxone has to be administered. So naloxone administered is equal to yes. And one of the following two things needs to be marked in the report, either a primary impression of suspected opioid overdose or a service-defined question of opioid overdose is equal to yes. And this just gives you a preview again of what our numbers, just a general feel for what our numbers look like. So these are patients for whom naloxone was administered. So you can see the top two primary impressions for which naloxone administered are, no surprise, suspected opioid overdose and poisoning overdose/drug abuse. But you can see the number of other chief complaints for which naloxone was being administered was not negligible, particularly the unconscious, cardiac arrest, or altered level of consciousness. We would be missing some of our opioid overdoses if we did not add that second question into the analysis. So we'd be sacrificing too much sensitivity in favor of specificity. We'll highlight here that just for additional reading, we've included the link here, and we can certainly provide this to anyone who needs it for our newsletter, our special opioid newsletter that highlighted our opioid API with ODMAP. And at this point, I'm going to turn the reins over to Dr. Thompson. Now that you know what we were using as our trigger to send opioid cases to ODMAP, for him to talk to you about how we went about accomplishing that. So Dr. Thompson, the controls.
Thank you, Dr. Chesman. So that's the background information that you already have. And now moving to the actual API, the ODMAP API. So ODMAP has a simple custom API, and API, that's application programming interface. The API allows automated transmission of EMS identified overdose cases from an EPCR system to ODMAP. So Dr. Chesman went into details how we identify an overdose case from within the EPCR system. So once we identify the overdose cases, we use the API to transmit those cases automatically to ODMAP. So first, to begin transmission of data to ODMAP, you need an API user account. That's the first thing you need. And once you've acquired the user account, integration with the API is straightforward and requires few steps. So first, how do you acquire the account, the API user account? There's a link here through the ODMAP or HIDAP.org website. You can go directly to this link, or you can go to odmap.hida.org and click on register as a new user. And the process is very straightforward. So once you've acquired the API user account, how do you use the API? We've identified 6 simple steps. The first one is to identify where your data resides. That's the first step in developing or using the API. And once you've identified where your data resides, you need to have access to that data repository. And for us in Maryland, we are very fortunate to have a local copy of our database. So, and this is almost close to real time, as incidents are being entered through our EPCR vendor. We have a replication of that coming with a latency less than 20 minutes, anywhere between 5 minutes to 20 minutes. So having access to that local database is very advantageous for us. And the third step is understanding the data set. Next is data elements. You need to have a thorough understanding of the data set, especially for the fourth step, and that is defining a suspected overdose case. We have to develop an algorithm, and this step is very key. It's key and essential, because if you don't have the algorithm right, then you're going to be submitting bad data, right, to the ODMAP folks. And like you saw previously, Dr. Chisholm talked about when we started the process, it was very simple. We checked for naloxone administration. If Narcan was given, we submitted that to ODMAP. And we later discovered that we were actually over-reporting because not all cases of Narcan administration were OD. So this step is really essential. And once you have that down, the last two steps are a little bit technical. And this is where you need to have a knowledge of a modern programming language, anything like Java, C#, and for those technical folks in the room. And next is the ability to format the data in JSON. And once you do that, identify the records and format those records into a JSON format, you can submit to the ODMAP. So what are the required data fields that are for ODMAP? There are 4 data points that are required for the API. So the first one is the date and time of the suspected overdose, then location. And with location, lat and long is required for geocoding consistency. However, the API accepts the address as well. But for our implementation, we discovered that without the lat and long, the API does not accept a record. So, and our EPCR vendor geocode the lat and long of the incident scene for us. But there are some cases where geocoding doesn't work, where we have the actual address and the lat and long is not available. So in that case, we use Google. Google has a geocoding API, and we leave the first 10,000 records. It's free per day. So we use the free service from Google to geocode addresses that were not geocoded from the EPCR system by our vendor. And the third data point is the fatality status to determine whether or not the incident was fatal or non-fatal. And the last data point that's required is naloxone administration. And with this, it's actually counting the number of times Narcan was given. So there are cases where you have an overdose case and an overdose incident, and the proper dosage of Narcan was given just once, and there are times where it's given multiple times. So ODMAP wants to know the quantity of dosage that was given. And if this is not available, to take unknown as a value. So in addition to those 4 required data points, The API also accepts additional information, including case or incident number, the victim's age, the gender, primary suspected drug use, and additional suspected drugs, and also the clinician or the person who gave naloxone. And additional data elements are optional, whether the victim was transported to a hospital and whether the overdose was a part of a multiple victim overdose incident. And all of these fields, including a data dictionary and other useful implementation information, are available in the API documentation. And the API documentation can be provided by the folks from ODMAP. So there are times from our experience when we first started submitting this, there are times where you have law enforcement and EMS responding to the same incident. And ODMAP allows law enforcement and EMS to submit a record. And when this happens, there's concern of possible duplicates. So the good thing is ODMAP API has duplication checked that's built in. So the API looks to see if an overdose occurs within 285 feet or within an hour after or before the incident time in an existing record. And if that's the case, then ODMAP considers the new record that's been submitted through the API as a duplicate. And I think this is very, very helpful. All right.
Thank you,
Now,
William.
I will turn it over to Dr. Chisholm.
Thank you, William. Appreciate that. Just to kind of summarize briefly with the remaining time, and then we'll certainly pause for any questions you have. I think it's important to highlight the API value. The first thing that this does is it unloads the burden of data reporting for EMS clinicians. We've got enough on their plate just treating the patient and trying to convince the patient of the need for treatment or transport. But again, we want to make sure that these data are being reported accurately. So working with our partners at Washington, Baltimore, HIDA, what this data enables, so provided you're submitting this data, you've decided which data you want to submit, the data enables accurate tracking as well as spike alerts. So you can, within ODMAP, set up alerts that are customized and that allow you to identify clusters of overdoses. And importantly, with the API, you might say, what is the other value? Why not just have EMS put it in manually using the app? The other thing is that this is automated, and over 80% of the data in the system from EMS is captured within 27 hours of the incident. So we can say reasonably so that this reflects current state. It's not reflecting something that happened last week or a couple of days ago. The only reason it's 27 hours out from the incident that it takes us 27 hours to get 80% of the data is because we do allow for a 24-hour time frame for an EMS report to be completed. If we went to complete the report within 6 hours, that number would drop precipitously. So what else does it do? It enables preparedness and response for opioid overdoses. We link this with our public health partners. It enables resource deployment of things like fentanyl detection devices, as well as leave behind naloxone. We're very careful to keep protected health information out of this database because there is a mix of law enforcement, EMS, and public health all accessing this data once it lands there. But again, this is a way, just to sum up, this is a way for us to accurately communicate the data that we're collecting to our public health partners and enable them to make a response, and also enable spike alerts to occur so that we can tell where things are really taking off. We've also worked with some of the partners at ODMAP on projecting both certain days of the month or certain months that are higher in terms of opioid overdoses than others. Again, all with the goal of trying to increase the public health response to opioid overdose. So again, we hope you've found our presentation useful. We've included both of our email addresses here at the bottom. If you ask me what an API is, I'll probably look at you funny. So if you have technical questions, certainly feel free to contact William. And if you have sort of more clinical or philosophical questions about why we're doing it or how we're doing it or how we decided on a definition, I'm probably more the person for that. So together we make a good team. So thank you, William. And Mary and Kathy will turn it over. Go ahead.
Well, I forgot to add that the frequency which we submit data to ODMAP is every 15 minutes. Every 15 minutes we submit data.
Right, and so that's important. So even though, so the system is constantly looking for new reports every 15 minutes, and if it gets that report in the system, it will send it over automatically.
Well, thank you, Dr. Thompson and Dr. Chismark. This is Mary Hedges again, and I'm going to go over direct some of the questions to you that we have. This one looks like a question for the medical director, Dr. Chismark. Do you have it from Justin Romanella in New Hampshire? Do you have a statewide protocol that facilitates EMS providers leaving naloxone kits behind?
Yeah, it's a great question. We have an optional protocol that enables them to do it. And we've had about 14 of our 26 jurisdictions make use of that. We're really at the point where that will probably be converted over to a standard protocol. The Department of Health pays for the naloxone, and there's really no reason for them not to do it. They're able to dispense based on a standing order that comes from one of our deputy health secretaries that's renewed every year.
Okay.
That's how we got around the dispensing question there.
Thank you. Next question. I think it's been answered, but it's probably worth asking again. And I think we'll direct this to William. So, Dr. Thompson, and this is from David Harden in Arizona. Does ODMAP trigger question on naloxone administration distinguish between naloxone administered prior to EMS arrival, e.g. law enforcement, bystander, family, etc., and that administered by EMS? So
no, we just look into the EPCR, we check to see if Narcan was given, even though we capture who actually gave naloxone. But as long as naloxone was given, whether prior to EMS arrival or not, we submit, it meets our algorithm. So that gets submitted to ODMAP.
Yeah, Mary, just as a general point, we do, after all of our medications, naloxone particularly, collect whether it was administered by EMS or administered by a bystander or prior to our arrival, just in general.
Okay, that helps. Next question, and I believe this is a question for Dr. Thompson, from Ellen Lycan. If our EMS system is using NEMSIS data collection, will all 4 required data elements be collected automatically?
Yes. Yep. So all 4 elements will be collected automatically because we look at the time, basically the date and time of the incident, the location of the incident. And with fatality, yes or no, that's not, you have to look at like DOA, right? So you need to look at some other data elements to derive whether it was fatal or not fatal.
So that would be the disposition.
Yeah,
code.
the disposition.
Yeah.
So whether it's DOA or not, yeah.
So Mary, just in general, we've selected disposition codes similar to, pronounced dead on arrival, or, had CPR and intervention but not transported to the hospital, pronounced deceased after a termination of resuscitation. And I don't know if you know all those specific disposition codes, but those should still be NEMSIS codes.
Yeah, they are all NEMSIS codes.
And naloxone administration would be a medication procedure code.
So the answer is yes.
Okay, thank you. Dr. Thompson. Now we have the next question. I'm not sure yet who this should be directed to, so both of you put on your thinking caps. This is from Terry Mullins, the EMS director in Montana. The primary purpose of ODMAP is to support harm reduction purposes. There is ability to use the data for interdiction purposes. How did you overcome the tradition of a firewall between using data for public health and PI and the potential for its use in interdiction?
Yeah, so that's a great question, Terry, and thank you for that. That was a concern early on was, ensuring that we struck that balance between the law enforcement interest in interdiction and public health outreach. I would say we're willing partners with public health. One of the things that we were very careful to keep out of that legislation was protected health information. I will say that most of our law enforcement agencies have taken more of a stance around, again, not directly charging those who have experienced an overdose and really focusing more of their attention on the people who are distributing. I will say, again, while it's not universal, most of our law enforcement agencies carry naloxone and administer naloxone prior to our arrival. That is a concern, certainly, but we felt again that the greater public health interest was paramount in this case. And then from a practical standpoint, our legislators felt very strongly that this needed to be done, and so part of it was we were legislated and required to do it in a certain way. So, William, I don't know if William actually predates my time at the agency, so he was part of some of that initial discussion.
Yeah, and if you look at the law, the first two slides, you will see that in Maryland, what's required is exactly the required data fields from ODMAP. So someone actually kind of knew about ODMAP before putting the law together.
Thank you. That helps a lot. Okay, this question is from Thomas Benal. On the duplicate calls of 280 feet in 1 hour, if you have a particularly high opiate OD corner of the street, do you tend to miss cases on ODMAP? Can that duplication setting be modified or removed?
Well,
that sounds like a answer.
So this is just a check that's put in place by the ODMAP folks, and I don't know, it's unlikely because when there's an overdose, we submit that to ODMAP, so you have an existing record. So the situation described would be true if at the same incident, within an hour, you have multiple dispatch calls, right, going to that same incident for overdose. And
within 2 hours, an hour before and an hour after.
Yeah, yep. So it's really, really unlikely for that to occur.
And I guess I would say the key thing to understand about that is that it is still keeping one record in the system. It's not booting both of them out. And the record that it's booting out actually is the EMS record. It's accepting the law enforcement entered record from the person that is there on the scene, punching it into the phone. So yeah, it is again a balance of sensitivity and specificity. I think that's probably the biggest lesson you can take away from this one today is trying to balance sensitivity and specificity in reporting can be a bit of a challenge with this. So that's what I would have to offer on that one, Mary.
Okay, well, thank you. And we have one more question, and I believe we'll probably wrap it up and move on to the next speaker after this one. It's from Paige Hargrove. Paige asks, would you be willing to share your protocol for leaving kits behind? Also, how do you track when kits are left? Do you use image trend, or is this captured in ODMAP?
That's a great question. Absolutely happy to share that. Our protocols are all public facing, so Mary, if it's easiest for you, I can send you the direct link to the protocol and the page number. And the second piece was we do have an ability to capture that in the image trend EMEDS database. The jurisdictions preferred to report that directly to the Department of Health. I think I mentioned Department of Health pays for all these extra naloxone doses, and so they wanted a direct accounting directly to the Department of Health. So when they send that email to the Department of Health saying we used our 75 doses, they copy us on it. That was just how they chose to do that. But you certainly could track it using the EPCR.
Okay, well, thank you. Okay, one more question, Scott Winston, and then, then we'll cut it off. So Scott Winston from Virginia says, what type of discussions that occur at HIDA about the data reported to ODMAP? And have any operational changes occurred in how you respond to OD suspected EMS calls?
So I probably can't comment as much on the internal discussions at HIDA. Like within HIDA, I think probably early on our greatest discussion point was what criteria do we use to define an overdose. We had quite a few, meetings back and forth and analysis driven at that. But I guess I can't actually say what they're discussing internally. As far as the drive towards, how do we approach overdoses? I think we've used a lot of this data to show that many of our overdoses do not go to a hospital, and that's driven naloxone leave behind. It's also driven in a couple of our jurisdictions something called safe stations, where anyone that's experiencing an opioid use disorder is able to come to that station, and we'll link them to help with any of our allied partners. And so some of the counties have said, "Wow, look at this, look at this ODMAP data, and this station here would be a great safe station for us to have." Hopefully that helps answer that question, Scott.
Thank you. Well, thanks so much. I'm sorry if anybody else questions we didn't get to, but I think now we're going to turn it over to our speaker from Connecticut, Catherine Hickox, who's going to talk about Connecticut's Office of EMS approach to reporting overdose data to ODMAP. And Catherine, we'll turn it over.
Good morning. Can you see my slides?
Yes.
Oh, excellent. Glad to hear it. Good morning. My name is Catherine Hickox, and I am with the Office of Emergency Medical Services of the state of Connecticut. And I'm going to tell you a little bit about our SWORD program this morning, which is the statewide opioid reporting directive. Starting off with some demographics of the state of Connecticut, we are the third smallest state. We've got high population density in that small space. And then, of course, there's this key fact. We are made up of 8 counties, but we do not use county government. We have 169 towns and a number of data sharing challenges. Just some trends, which I'm sure we're all aware of from 2012 forward. And sorry, one slide out of place there. In 2016, we entered into core strategies that were implemented by our former governor, and the primary objective being obviously to reduce opioid risk within the state. And our new SWORD program was implemented to provide surveillance of the opioid epidemic, which is ever changing, and to create an early warning system. And ODMAP has really been a key component of that program. So similar to Maryland, we implemented, or I should say the state of Connecticut implemented a new law in 2018, which essentially requires EMS within the state to report any suspected non-fatal or fatal opioid overdose. And our implementation of those reports is a little bit different in that our EMS professionals are calling directly into Connecticut Poison Control. And this new reporting directive started or was fully implemented on June 1st of 2019. And since then, we have mapped over 10,000 opioid overdoses and over 8,000 patients have been administered naloxone. ODMAP obviously is capable of displaying heat maps, which have proven to be quite valuable to many of our local public health partners. And this is just an example of some of the reports that are available within the system. So,
yeah.
Go ahead, sorry.
Sorry to interrupt you, but your slides aren't advancing if you're able to advance them.
Oh, interesting. Okay. Where are we stuck? Are you back at the beginning? Sorry.
At the title slide.
Okay. I have been advancing them on my computer, and you're not seeing that.
Oh, there they go.
Are they still
Now.
visible?
Now you advanced it.
Okay. And can you see them now?
Yes,
And are they advancing?
yes, yes.
Excellent. Okay, not quite sure what happened there, but I will advance through them quickly. There's the state law. They're still going forward? Yes?
Yes.
Excellent, thank you. Heat maps. Okay, this is where I had advanced to. So at the beginning of the directive and through towards the current time, we have a number of handouts that have been made available to our EMS services to prepare them for that call that they're going to make to Connecticut Poison Control. Essentially, an EMS professional picks up the phone following an overdose, and they are calling another human being, and they're answering a series of questions. We want to make sure that our EMS professionals are prepared with the appropriate data points, and then those data points are being entered into actually 2 parallel data systems. So here's an example of the call. They call poison control. The poison control specialists enter the information, and then poison control also follows up with the patient at the hospital. So the 2 data programs that I was referring to, or the parallel data sets, are ODMAP and Toxicol. The benefit that we found with this dual system is that as these overdoses are being entered into Toxicol, there is room for an expanded narrative. So there are additional details that we are not able to capture with ODMAP, but ODMAP is extremely helpful in providing that near real-time information as to where the overdoses are occurring. So our cases include the answer to all 11 questions, hospital follow-up on details, and the key narratives that I was referring to. This is an example of a narrative that was extracted from Toxicol, and the screenshot is from ODMAP. So Toxicol allows us to look at trends in the presence of certain drugs. And we also have epidemiologists that are incorporating not only the Toxicol and ODMAP data, but also bringing in a third data repository called Epicenter, which is hospital-based. I just want to confirm that the slides are still advancing.
They are. Thank
Excellent. This is simply a shot of what the poison control specialist sees when they are entering data into ODMAP. And there are countywide spike alerts, which are set off by the system. They can be set up by account holders or account administrators. One functionality that would be very beneficial to Connecticut would be the ability to set up slightly smaller target areas based on zip code, which is a request that we've made of Washington, Baltimore, HIDA, as the lack of county government makes the countywide spike alerts a bit broad at times. However, we are using them quite successfully. So our Department of Public Health epidemiologists review the toxicol syndromic surveillance in that epicenter application that I was referring to. And then ultimately, we also take a look at the data from the Chief Medical Examiner's office in order to confirm cause of death. One thing that we have established now over a year into the SWORD program is that it is challenging for EMS professionals to accurately report cause of death. Obviously, we think we're probably only in the low 20% range, 20 to 23% successful reporting of fatal drug overdoses. And so we are using the Chief Medical Examiner's toxicology data usually 8 to 10 weeks out from incident to establish cause of death. That information is not currently being updated in ODMAP, but we are looking at the possibility of possibly reconciling those cases back into ODMAP. Skip this slide. This is some current SWORD data that we have been able to generate with the use of ODMAP. And we also produce a monthly newsletter, which contains data reports, data reports from ODMAP, Epicenter, and as well as reports or articles that are not only geared toward EMS, but also towards our local public health partners as well. So there have been a number of research initiatives dealing with ODMAP or accessing ODMAP data. We had a case study on Hartford fentanyl contaminated crack, frequency of multiple opioid overdoses per individual, prevalence of non-fatal overdoses preceding fatal overdoses, naloxone and cardiac arrest, and so on here. With our calls coming into the Poison Control Center, we are pretty effectively able to make the separation between naloxone that is being administered by EMS and or bystanders versus law enforcement. We have produced reports including those data points. The strengths of the program obviously are early warning, the ability to surveil across town boundaries, demographic information. We have recently added a race and ethnicity question to our toxicol database. That is not something that I believe has yet been included in ODMAP, but again, it is a request that's been made by our state. Some limitations. Is the EMS underreporting? I mentioned that only 20% of our fatals are currently being accurately reported. The statewide compliance is between 70 and 80%, and we do have a compliance model in place where we are in constant contact with our largest EMS providers on a monthly basis. The time lag of reporting and spike alerts being only countywide. So future challenges and hopefully future improvements, I've mentioned many of them, would be obviously improving EMS compliance, being able to work with HIDA to separate by zip code, and finding a legal way to share some of the PHI, which is made available through the Connecticut Poison Control Toxicol. And obviously, benefit of EMS engagement, we encourage all of our emergency medical services instructors to include SWORD as part of their training programs so that everyone is fully aware of their obligation of reporting under the law. And our future goal is to join Maryland and many other states in implementing in the naloxone leave behind program. And we are currently drafting a protocol that would allow for that to take place. And that is all I have.
Well, thank you, Catherine. That was very helpful, and it's interesting to compare two different approaches to reporting to ODMAP. One question I had is, you said you had 70%, about 70 to 80% compliance of EMS clinicians reporting the data. How long does it take, on average, a guesstimate for them to report the data to the poison control, and how do you ensure compliance or boost compliance?
Sure, I think we're finding that the majority of incidents are reported within 12 hours, which is terrific. Some obviously longer than that, but not bad for an average. As far as compliance is concerned, it is a sampling. Essentially, we have, as I said, open dialogue with, it's a data sharing initiative with 20 of our largest EMS providers in the state. They do 90% of the EMS business in the state. And it is a combination of both volunteer and commercial services. And what they do is that they forward data reports or data exports from their EPCR systems with an estimate of the number of calls that they feel met the reporting requirements for the previous month. And we then compare those to a report that is generated by Connecticut Poison Control on a monthly basis, and are able to work out that, X agency had, let's say, an 85% compliance rate for the previous month. And we then aggregate those percentages based on that reporting.
Do the EMS clinicians call in the report to the poison control, or is it done electronically?
They do. So we have one commercial service, AMR, is implementing an API in Connecticut. It's the same API that they're using in a number of states. And honestly, the quality of the reporting that is done person to person between the EMS provider and poison control is much better. And so the way our law currently reads, even if somebody is, let's say, an employee of AMR and the API is uploading a report, they still have, that human being still has to call into poison control and make a report. And we do have mechanisms in place within the Connecticut Poison Control system to dedupe or remove that duplicate record.
Okay, well, thank you. If anybody else has questions, please be sure to add them to the question box or the chat. But I don't see any other questions at this point. Again, I want to emphasize that the handouts are available. And Kathy has posted them in the chat box, the link to them, or in the in our session information here. And also that this session has been recorded and will be available on our YouTube channel. Kathy, do you have anything else you would like to add as we close out this webinar?
No, thanks, Mary, and thanks, Kitty. That was a very informative presentation, and the contrast between programs is very interesting too. So we appreciate you sharing that information. I am not seeing any more chat or questions in the box either, and we are at the top of the hour, so we'll wrap things up. But thank you very much. Oh wait, I have a hand raised here. Terry, Terry Mullins is. Did you leave? Just seeing if I can unmute the microphone.
Yes.
The hand there.
Terry sent a
Okay,
text
gotcha.
rather than a question. Great presentation.
Yeah, we got that. Okay. Well, again, thanks very much to our speakers. Thanks very much to our presenters. We will be posting the presentation on our YouTube page. That you can get the link to that from the NASEMSO website. We'll send out an email message afterwards so folks know where to access that. I've been trying to include those also in Washington Update. So I know the speakers are very welcoming to questions from anyone about their programs, and happy to provide whatever documents and protocols that might be of benefit to you. So with that being said, we thank you again for attending and wish you a great rest of your day. Bye-bye, everyone.